So what I'm trying to show you right now is the patient's left nasal cavity with the endoscope, and you can see that there's a huge deviation towards the left side, very little passage for airway. That's the midline, and you can see a little bit of caudal dislocation on the right side. So this patient came with complaints of constant left-sided nasal blockage, left-sided congestion, which would lead her to have a cheek pain, that is a left maxillary cheek pain, also left frontal and left temporal headaches as well. So, however, this patient did not have any hyposmia or anosmia. The sense of smell was perfectly fine. You can see a little bit of mucoid secretion collection happening there. So I'm trying to put my endoscope inside, but I'm not able to. So at the area of the nasal valve, I'm getting a lot of resistance. But eventually, I'll try to decongest the area and then negotiate the endoscope inside. And I'll show you the inferior turbinate status and the status of the septal deviation posteriorly and superiorly. So this is the patient's right side, and you can see in the center the septum is almost straight. You can see a little bit of mucoid streaks, and in the center you can see a huge swelling. That is the inferior turbinate, severely hypertrophied. So in case we can remove this patient's inferior turbinate around 90%, we can reduce that along with septoplasty. So a little bit of decongestion I have achieved, and I'll try to negotiate the endoscope inside. As I'm trying to go inside, I can see the patient's inferior turbinate, which is kind of boggy, which is under hypertrophy. But what I can appreciate is that the patient is having a good airway inside. So it's only a severe deviation on the anterior side, and I can see something superior deviation as well, that is the high DNS. So this patient requires septoplasty.